Have you noticed that politicians struggle to enact the things they run on? That regardless of who wins elections, lawmakers find they cannot pass whatever legislation they like. They find themselves bound by what is popular, or at least their sense of it. They can only act within a narrow set of ideas, and that range is called the Overton window. And on the Overton Window podcast, we look at issues around the country and talk to the people who change what is politically possible. Now, it feels like we have been stuck in a world where the cost of medical care keeps increasing and with little in return, where government assistance programs like Medicare and Medicaid cover more services and more people, and no one sounds satisfied. So what is going on? How did we get here? And what is the Overton window for medical policy? Today we are joined by Blase, the president of the Paragon Health Institute, to shed some light on this issue. Brian, welcome.
Great to be with you, James.
So is my summary of these trends correct? Like, what's going on here?
Yeah, well, I would say, there are people that are satisfied with the healthcare sector. So if you ask people on Medicare whether they value the Medicare program, the vast majority would say that they do. If you ask people on Medicaid, many of them would say they do. If you ask people that have employer-sponsored insurance, many of them would be satisfied with their employer coverage. I think we've done a pretty good job of suppressing who pays for all of the healthcare spending. We've dispersed so much of the cost to taxpayers, and employees don't know how much they're actually paying, that they pay the full share of the premium. The employer is not paying a portion of the premium. So I do think there is frustration with the healthcare sector, clearly. And people are frustrated by rising costs, probably more than any other aspect of it. But there are people who have obtained benefits through government programs, a perceived benefit through employer plans that like what they have, which makes changing the healthcare sector politically difficult.
Well, let's talk about that frustration, because I think that's going to be some of the main concerns. I mean, people are worried that the costs of the system are going to rise far beyond anything's ability to pay, at least for the longest time that I've been around. Like, that's been this huge concern, with this idea that maybe something will change that cost curve, and it just hasn't happened yet. So what's going on there?
Yeah, I mean, just a few weeks ago, there was a survey of employer plans, and about half of all Americans get their coverage through an employer, either their own employer or the employer of a family member. And those premiums increased 7% from the previous year. So the average premium is closing in on $25,000. And I think people are getting increasingly frustrated with high healthcare costs too, because the deductible is the amount that an individual has to pay before the plan starts reimbursing medical expenses. The deductibles are increasing. So more Americans are actually feeling the high costs of medical care.
Well, I mean, I want to talk about that a little bit, because it feels like the complexity of the insurance product that we are getting have just increased astronomically, in the past 40 years, and it covers a complicated sector. Now, normal insurance is, I have this possibility for this financial risk. I want to get covered for that financial risk, and it seems like the insurance that we have doesn't really do that. Sometimes it does, sometimes it doesn't, but it feels more like you're buying this pre-arranged pool of goods that you're sharing with the other people in your insurance pool. Or am I thinking about this completely wrong?
No, I think you're spot on. I mean, health insurance is not a typical insurance product. So you think of typical insurance products, life insurance, homeowners insurance, your car insurance. You are protecting yourself against financial ruin, right? A very low probability event. And obviously that's present in healthcare. Like, you can get involved in an accident, you could develop a very expensive medical condition like cancer, that is relatively low probability but carries high financial cost. But a large part of what health insurance also does is, like you mentioned, it's the prepayment of medical services. It is the individual sort of giving up the negotiating and control to a third party, whether that third party be a government bureaucracy, a health insurance company, or an employer. And that is fundamentally what makes healthcare so much different than every other sector of the economy, is that the consumer isn't in control of the financing.
So when you say that individuals have given up control over negotiating their benefits, it seems like that should be, at least in theoretically, a good thing for them. Like you put it in the hands of insurers who are experts in what things cost and can understand, like, how much these things get used, and set and more and be better able to set the terms of service than an individual can. But I feel like that things have just gotten more complicated, more bureaucratized, and less friendly and less costly, or sorry, and less friendly to the customer.
Yeah, I mean, you have all these rules now set up because people aren't spending their own money. People aren't directly price conscious, right? Because a third party payer, whether a government program or the insurance company, is paying the medical expenses for the most part. So then you have to set up a whole bunch of rules, whether it be from things like prior authorization, where the doctor has to check in with the insurance company over whether something that the doctor thinks is in the best interest of the patient, whether that's allowable or not, to the government role in establishing which services get reimbursed and at the reimbursement rate. So if you think of the economics of price controls, right, price controls, the price can be set too high, above the market price, it can be set too low. And if it's set too high or too low, you have problems, right? You can have shortages, or you have surpluses where too much is going into a certain area. But you've got all this sort of economic dislocations and chaos. And the American healthcare sector is characterized, one of the central features is that a federal bureaucracy in Washington, D.C. decides what gets reimbursed and what the reimbursement prices are. That's through the Medicare program. And private insurers, which I think is a real problem, have tended to just go with Medicare's reimbursement rates. So you've got a very political process where the entities that are going to be subject to this price regulation, they lobby, they try to get favorable terms. So you've got in healthcare so much of our resource allocation determined by the political system rather than a market-based system.
All right, so there are a couple of things that you'd mentioned in this third-party payment. No one's really paying the direct costs. The effective price controls, when Medicare is such a huge provider and when everyone defers to it, we've just agreed that these things are the prices. And those prices are not set by the market, they're set by political considerations. So those are two big ones. And then the last one that I think you mentioned, sir, dig in on that a bit. It's because I think that was the key. And unfortunately, I kind of forgot what exactly that was.
So let me mention actually I think another important one, because those everything that we've talked about so far is on the demand side of the market. The
Mm-hmm.
government also, so the government sort of inflates demand. We've got all these third party payment problems. We've got price controls everywhere in the healthcare sector. We also have severe restrictions that government places on the supply side of the market. So we're artificially restricting supply. 35 states have these things called certificate of need laws.
Mm-hmm.
A certificate of need law prevents a sort of hospital from adding capacity, prevents sort of competitors from coming into the market and challenging the incumbents. And by the way, incumbents can sit on the boards of these certificate of need laws, which deny permission to competitors to come into the market. You've got a lot of restrictions on what medical providers can do. So you've got like scope of practice limitations. You've got a lot of medical professionals like doctors that want to restrict what nurse practitioners or physician assistants can do. So we've got sort of
And
government problems on both the demand and the supply side of the market.
so for the certificate need and scope of practice, I'm actually seeing a lot of stuff in the States trying to do something about that. I mean, the certificate, the hold up on certificate of need is that competitors don't want to make it easy to get, or people don't want it to make it easy for competitors to enter the market. They put in a lot of their political weight, but we are seeing some changes in that around the country. Same thing with scope of practice. Those other things, third party payments, price controls at the federal government level, it feels like there's nothing there like that. Those are just the world that we live in American healthcare right now. It doesn't have to be that way, but it feels like that's like the system that we're stuck with and no one's trying to do anything about it. Is that right?
Well, and you sort of had Obamacare come in, and Obamacare was passed in 2010, and the motivation there was largely to make sure that everybody had access to affordable health coverage. But mostly, Obamacare was a giant expansion of the Medicaid program. So we have Medicare, which is mostly for seniors and some people with disabilities. And then you have the Medicaid program, which is run at the state level, but where Washington provides an open-ended reimbursement of state Medicaid expenses. So you've got sort of on the demand side, you've got all of these government subsidies that sort of just inflate what healthcare prices are and inflate overall spending. So if I was to give you sort of my main frustration with the American healthcare system, it's that we have created a whole bunch of perverse incentives so that Americans that make decisions aren't focusing on value. They're not focusing on what gets us the best health in sort of the most efficient way. We sort of just get all of this spending and sort of the power of the political power of the healthcare industrial complex has just set up protection from government policies from competition. And when when issues come up around affordability, their favored response is never to look at the regulations or the policies that have pushed up prices and spending. It's just to continue and grow subsidies so that the taxpayer then faces more of the burden for the rising cost of these programs.
What are some of the policies that you'd like to see changed that would deal with those perverse incentives?
So I think on the demand side, the number one policy change is to return the financial control to the consumer. So if you think about Medicare reform, and this is talking about the Overton window, right? This is sort of long range policy objective, but it would be to turn the Medicare program more into the Social Security program. So the Social Security program, it's got its own financing challenges because of the baby boomer population, but it's just government cutting checks to seniors, and then the seniors get to spend the money the way that makes them the best off. So they have incentives to get value for that spending. So transforming the Medicare program to sort of this cash program for healthcare, like seniors would have to use it on healthcare. You'd probably have to put rules where they have to buy a health insurance plan with a portion of the spending that they get, but where the incentives there for the enrollee to make the decisions that best work for them. In the employer market, and this is one of the things I worked on in the Trump administration, like one of the problems with employer-provided health insurance is that the employer is selecting the plan for all the employees. There's not another major financial product that people purchase that the employer decides for the employees what the best product for all the employees working for that employer are, right? So instead of the employer selecting the plan, they just provide a contribution, and the contribution could get the same tax preference, right? The premiums for employer provided plans aren't subject to federal income tax, but the employee can then take that contribution and use it on the health coverage and health care that works best for them. One other quick policy here: health savings accounts. Health savings accounts are the way that a consumer has the best incentives to make sure that they get the value for their money, because the value of the health savings account is owned by the consumer, and anything that they save grows with interest over time, so they have it in the future for future healthcare expenses. So anything that we can do to, on the margin, move away from the third-party payment to first-party payment through expanded health savings accounts would improve the consumer ability to shop and get value.
Okay, so let's dig in on that a little bit. For the Medicare recommendation, again, treat it more like an entitlement program where you're entitled to a financial contribution. And the idea for this one is like, we're going to get away from the centrally planned thing. We're going to try and let local knowledge and incentives determine plans, terms, discounts and rates, and now someone actually has an incentive to try to economize on these things at the business and consumer level. So I can understand the theory behind that. It seems like that's the toughest one to get. Like Medicare is so ingrained. And it's ingrained in particular ways. Like it seems like this popular program, like the federal government's going to be here for you to provide for your medical benefits when you reach retirement age, and people want that. You're saying we can have that, but do it better without all these other problems. Why is that such a huge lift for the political system?
Yeah, and actually, it seems like we're moving in the wrong direction. Like there have been proposals. Former Speaker of the House, who was also Ways and Means Committee Chairman and the Budget Committee Chairman, Paul Ryan, had legislation with Ron Wyden, who is now the Chairman of the Senate Finance Committee, which is the key committee in the Senate that deals with sort of the intersection of health and tax issues and Medicare. They had a premium support proposal, which wouldn't be the same as sort of what I described, where the senior gets cash and then can use it on the health care that works best for them. They would sort of have a set of plans that they could apply the premium support contribution to. And congressional Democrats and even some Republicans have sort of walked away from this sort of premium support model. And I think it is, Medicare is just an issue that gets demagogued. And if you make, if there's proposals out there to reform the program, to improve the financing of the program, some people claim that it's taking away sort of this Medicare guarantee where the government is going to pay for anybody's health expenses. Now, part of that is that the Medicare program does not work the way that most people think it works. So the traditional sort of the fee-for-service Medicare program, patients have a 20% cost sharing without any out-of-pocket limit. So there is, in the way that the rules are set up, there is no limit to the consumer's financial exposure in fee-for-service Medicare. It's one of the reasons why most seniors buy sort of supplemental Medicare plans that provide that additional financial protection. It's also one of the reasons why Medicare Advantage has grown in popularity so much. So Medicare Advantage is about half of all enrollees enroll in Medicare enrollees are in Medicare Advantage right now. And with Medicare Advantage, the senior chooses an insurance plan that works best for them, and those insurance plans can often cover services and benefits like vision and dental that traditional Medicare doesn't cover.
Isn't it weird that we have Medicare and as this government provided option, they set the terms, and now people are also expecting to purchase insurance on top of what is being provided.
Yeah, they almost all seniors do.
Mm-hmm. I I guess to go back to trying to get more trying to get better market incentives from the healthcare system that we've got. I mean, that is such a huge change that would need to happen at all levels of the medical service provider, because medical services tend not to operate like conventional consumer businesses. I mean, you go to the grocery store, there are prices everywhere. You ask someone, the car dealer, what this car costs, and they're going to give you an answer. You can negotiate over it, but they're going to give you an answer, and it's going to be pretty clear. You go to a medical provider and you ask what things cost, and the answer is, well, services or assistance is available if you need help. And it's like, well, okay, but what does that have to do with the price of eggs? So, this is a huge cultural change that actually has to happen, which government policy is it's encouraging some different kinds of behavior, it's encouraging other things, but is what you're calling for the first steps to try and change some of that?
Or is there a little bit of encouragement here? Because I don't. You're right. The whole sector is screwed up, and the sign that it's so screwed up is that there's not transparent price information. Any other part of the economy, right? The sellers of the products advertise their prices. It's impossible to avoid seeing what the price is when you go and shop for a car or go to the grocery store or try to purchase, insurance products online. There are several examples of a very simple plan design that could incentivize shopping among consumers. And it is, rather than the insurer negotiating all these separate rates with providers, they set an amount. It's typically called a reference price. And that is the amount they will pay for a given service, regardless of where the customer goes for that service. So there's a couple of really prominent examples of this. One is the California Public Employee and Retirement Plan more than a decade ago, set reference prices for orthopedic procedures, for cataract surgery, for things that are shoppable. And about half of what we spend on healthcare is sort of in this shoppable services bucket. So they set the reference price. If consumers could go anywhere, if they went to a provider that charged above the reference price, the individual would owe that difference. So they had an incentive to find out what the prices were and to go to the providers that charge less than the reference price. When they had that incentive, consumers started shopping. Now that isn't going to surprise sort of anybody. That's sort of just common sense. The most interesting part of this is, though, the high-priced hospitals in that area didn't like the fact that they were losing customers. So they reduced prices significantly. You had average price reductions of 20 to 30% at the high-priced hospitals. And all the change that had to be made for that sort of beneficial price mechanism to work was that the plan just had to pay a set amount and make that very clear to the customer that that was what the plan was paying. They could go wherever they want, but any residual amount above that would be the responsibility of the individual.
That is encouraging, Chung, because it does seem that in this policy area, there are some people who are working and trying to innovate. There are some people who are trying to, or at least providing some good recommendations for how to move the system forward. It seems like the biggest barrier to some of these things is public support. As in, the public debate that we're having is not about how to make the system better. It's things like, do we need to become like every other country and socialize medicine, or how much, how terrible it is that some people are facing bankruptcy over medical over their medical bills. And it doesn't seem to be like a lot of, here's the system that we've got now, here are the major problems, here's some of the ways that we're going to solve it. These things that you're talking about.
Yeah, I agree with that. I mean, I think one of the important policy focuses certainly for Paragon is preserving alternatives. Like we don't want the government to just regulate all these alternatives out of existence and say, look, if there's only one comprehensive health insurance model, and insurers and providers need to be so heavily regulated, right? So it's what can we do to preserve other options, whether it, for coverage, like there are health sharing ministries that operate different than traditional health insurance does. There are providers that basically just opt out of third-party payment and say what we're going to do is just work directly with individuals on like a subscription basis. So they just accept a monthly sort of retainer, and then we'll take care of that family's healthcare needs over the course of the contract period. And it's like essential that we fight sort of all of this centralization and standardization and regulation that really, I mean, there's this nexus between big government and big industry, where it is the big industry that really benefits from all of these rules that standardize and restrict the market, because those increase the entry costs for competitors to come in and disrupt the status quo.
Yeah, it is. It is unfortunate that a lot of public policy is geared towards giving private people, private individuals, benefits at the public's expense. I think there is a lot of that going on in health insurance and in medical provision policy, and I think we've put a lot of importance and respect and almost sanctimony in our health, in the ability to access medical care. And I think some people have abused that.
We want better healthcare access. Like that's why I do healthcare policy, right? We want people to have better healthcare access, and the best healthcare for them. And in order to improve healthcare access, we've got to reduce prices. And that means in many instances, we need to undo all of these government programs and policies that have created such perverse incentives that have restricted supply, the provision of care, prevented people from paying for care the way that works best for them and where they're incentivized to get value.
The way that you tend to break these kind of things, try and gear public policy towards public benefits more, doing some of the things that you're talking about, is by just raising the understanding, making the kind of things that you're talking about more popular, so that more people want it. Politicians want to pass popular laws, even if they step on the heels of powerful interests. It's what the public wants, and most people accept that. And frankly, that's a good way to get some progress in society. What are some of the things that you're doing to try and make these ideas more politically feasible?
Yeah, so I think I'll give you a couple of examples. One is building on the success of health savings accounts. So, I mentioned the benefits of health savings accounts earlier, but one of the policies that Paragon has developed is giving enrollees so low-income Obamacare enrollees get a subsidy that goes directly from the government to the health insurance company for the insurance company to reduce plan deductibles and co-payments. So we've developed a proposal that would allow the individual to get the subsidy as a direct contribution to their health savings account, so they have control over the financing. Now that is in some way, it's not going to be revolutionize the healthcare sector, because we're just talking about a few million people that would benefit from this. But it is a dramatic change in policy, so that we're taking the subsidy away from the industry and giving it to the individual. It's sort of like it's the school choice analogy. What we should do for healthcare financing is apply some of the principles for school choice. Another example is what we're trying to do on Medicare reform. We think there's been a lot of success in Medicare Advantage, that it has done so well because of the flaws with the traditional Medicare program. We also think there's improvements that can be made for Medicare Advantage that bring some efficiencies and make sure that it costs less for taxpayers than traditional Medicare. And Medicare Advantage is popular, right? People that choose Medicare Advantage is popular, something to build on, but something that we think there's ways to reform, and that a reformed Medicare Advantage can really set the stage for broader reform of the Medicare program.
All right, let's say that in 20 years you've gotten what you've wanted. What does medical care look like?
I think it's much more personalized. You have individuals in control of the financing, so the providers and the insurers are going to have to meet the demands of the individuals. And I think, assuming we have sort of radical deregulation, we've created a regulatory climate that's conducive to innovation and the creative destruction that moves the ball forward in sort of every other economic sector. So we'd probably move away from this huge sort of general hospital type structure for where everybody gets their healthcare benefits to sort of much more sort of specialty care with far more alternatives for Americans on where to go to get the healthcare that works for them.
Brian, thank you for coming on, and good luck in your efforts to shift the Overton window.